Give a thumbs up.
They're like a news anchor or something.
In 3.
What is the delay? Because there's probably going to be a delay.
I would expect so. I don't have any idea.
Good afternoon. Welcome to the webinar, Creating Value Through Continuum Integration. To remind you, this is the third in a series of webinars from Advocate Healthcare, following those on analytics and population health management. You can ask questions, but you'll need to do so through Slido, and we're going to break partway through the presentation around slide 17 to pick up a number of the questions. So start thinking about actually what you want to ask. Over to advocates. Do you want to introduce yourselves?
Great. Good morning or afternoon, depending where you are. I'm Don Kalkagner. I'm Senior Vice President of Population Health for Advocate Aurora Health and President of Advocate Physician Partners, which we'll explain in a minute.
And I'm Carrie Nelson. I'm a family physician, System Vice President for Population Health on the clinical intervention side. And then I'm also the Chief Clinical Officer for Physician Partners.
So we'll go ahead and jump into the slides here. And Carrie and I are going to tag team these. I'll talk at the beginning and hand them off to Carrie a little bit. So to set kind of who we are from an Advocate Aurora Health perspective, we were the product of a merger of two large integrated delivery networks approximately a year ago. This is just our stock slide that kind of talks about the numbers of who we are. Roughly, we're a $12 billion in revenue organization. We have 70,000 employees. We serve about 2.7 million unique patients, 27 hospitals, lots of doctors. The bottom line from this slide is within the United States, we are the ninth largest non-for-profit integrated delivery network in the country. When we think about population health as part of the merger, we are what we refer to as enterprise population health, meaning we serve that full footprint from the northern part of Illinois all the way through the eastern side of Wisconsin. Within the construct of that, we like to lay out what is our purpose, why do we exist? If you're familiar with the IHI's triple aim of improving quality, lowering cost, and improving service for our patients, that's really the circles on the outside. We added the fourth, enhanced clinician experience, because the quadruple aim is really where we're appointed, which really means we need our physicians to also be healthy, happy, and engaged in order to achieve those other three. If you look at the purpose statement in the middle, to engage our patients, physicians, and employers, at the end of the day, when we started this work, I would say it was all about the.
Seems like we've lost the audio for you guys presenting. We'll give it a couple of minutes, guys on the line, just for our APP to dial back in, so bear with us.
That's the right one. Okay. There you go. Okay, we're back.
Perfect. Thanks, guys. Do you want to pick back up off from this slide?
Yep.
All right. So what we were just saying is we are advancing from the Advocate Aurora Health Enterprise Population Health perspective to the Advocate Physician Partners perspective. You'll hear us refer to ourselves as APP. Prior to the merger, APP was and still today is its own entity that's attached to the Advocate Healthcare integrated delivery network. So if you begin looking at APP, we are really focused on a clinically integrated network. And if you look at what that means, and we'll get into what a CIN means in a couple slides, but we have about 6,300 physicians on our medical staffs at our hospital. If you look at those 6,300, approximately 5,000 of them are part of our clinically integrated network. 1,300 of them are independent physicians that practice at our hospitals but are not aligned to our hospitals directly. Within our clinically integrated network, we have about a third of which are employed, about 1,500, and the remaining are 3,500 independent physicians that have aligned themselves with Advocate by being a member of Advocate Physician Partners. So at the end of the day, what you need to know about what we're going to share you on the future slides is we have about 5,000 physicians, about a quarter of which are primary care, and about 3/4 of which are specialists. In terms of the population we manage, if you start with the outer circle here, we serve around 1.2, 1.3 million unique lives. To put that in context, in the market that we serve, there's about 9 million lives. So it's roughly 13, 14% of the lives in our market. We do have about 20% market share from an inpatient hospital perspective. If you go in a circle, a lot of the lives we serve are what we call just a pure fee for service. We do some type of activity and we get paid for it. But roughly 1 million of those lives are in some form of shared savings or global risk. And what we mean by that is there's an opportunity to bear financial risk or receive a share of the savings if we reduce the total cost of care. And if you go into that last bubble, about 325,000 are what we call globally financial risk lives, meaning the insurance company passes the financial risk for managing the book of business, the finances, to us. And if we treat the patients well, higher quality, lower cost, we get to keep the difference in the money. So it's a means of aligning our incentives. The way we go about working at...
You have to flip.
She did. He did. Yeah, we advanced the slides, but it looks like it hasn't advanced. Can you all still hear us?
Yeah. I can still see you.
Okay. We're assuming you can still hear us, so we'll keep talking. There's an additional slide. We should be on slide 6, which shows an organizational chart. And really, the reason for success, if you think about governance and managing these lives, is what we refer to as shared governance. So Advocate Physician Partners is actually what we refer to as a super PHO, which is a physician hospital organization, meaning our physicians and hospitals work together to manage these lives. The way we achieve this in a governance model is we have a board of directors that is comprised of half physicians and half administrators from the Advocate system. And then we have 11 local PHO boards, physician hospital organization boards, that we'll talk about on a future slide. And then, as in most boards, we have several committees that we use to engage our physicians. All told, of our 3,500 physicians, we have roughly 200 plus physicians engaged at a governance level. And the reason we find this important, we're now on slide 7, is we believe the way that you achieve engagement is basically this diagram here. So it starts with culture, and the way we think about culture is it's the way that we act based on all our organization's history of problem solving together. So it's an evolved way that we get work done, and we've been doing this for 20 plus years. So we have physicians and administrators working closely together, and we partner together to improve quality and reduce total cost of care. If you go down the right, we talked about governance. It's really important to us that it's not just administrators, not just doctors, but we're working together to govern. We believe, we know that there's a significant need for infrastructure. So we invest in technology, things like healthy intent. We invest in people like care managers, and invest in processes like being patient-centered medical home. We then reward behaviors with incentives. Then we essentially function as a virtual medical group, so we are transparent on our results, because remember, we are a membership organization, and then we provide feedback, and a lot of the feedback is given from physician to physician, but also reports that we share, and then that informs the culture and helps the culture evolve. I mentioned clinical integration. So clinical integration, the simplest way to think about it is it's physicians and hospitals working together towards a common goal. One of the key things is it has to be measurable. And from our chart here, this is our way of trying to show that it's evolved over time and continues to evolve. The more formal clinical integration program really started back in 2004 with our primary care ambulatory folks. And as you see throughout the years, we've added specialists. We've really tightened the metrics so that the physicians and hospitals are measured on the same things. We grew into accountable care, which was part of the ACA, the Obamacare exchanges in the country in 2012. And more recently, we're focusing on a high-performing network, which means we only want the best performing physicians within our CIN. So we'll ask those low performers to improve or to leave. And then at the same time, trying to pivot to more patient-centered outcomes, if you will. Along the way, the technology's evolved in a similar way. Back in the early years, we were focused on measuring things using Excel, and now we have some sophisticated technology behind us. Within that circle, we had mentioned incentives, and really key to that is we strongly feel you have to reward the behaviors you're expecting. And the way this is, it's essentially supposed to look like a funnel. And what we're doing here is within the way the United States market works, we have surpluses. If we take financial risk and we manage the patients better than the insurance company, any leftover money we get to keep. We also have incentive funding, which is what the CI funding is, and then shared savings on any of our other value-based contracts. So all those millions of dollars go into a big funnel. We take off some administrative costs and other pre-commitments, as we refer to them, and then we create pools of money to be distributed to the primary cares on the left, specialists in the middle, and then hospitals on the right. When we look across the country, what's interesting about us is a lot of folks don't distribute to the hospitals. You'll hear us talk about engaging the hospitals across the continuum is a key to success. One of the other keys to success is we believe you have to localize clinical integration or localize population health, however you want to refer to it. At the end of the day, I shared with you we have a super PHO board, but that board can set policy and make other decisions. But at the end of the day, they don't have direct connection to the 5,000 physicians. And so how do we work closely with the physicians? And the way we do that is we have local PHOs, physician hospital organizations, that are made up, they're centered around the hospitals and the physicians in their service area. And those PHOs are made up, again, 50% doctors, 50% hospital administrators. And they're the ones that we push the reporting down to from a clinical integration perspective, CI perspective, the quality, the total cost, et cetera. And so literally the way change management happens is the doctors on those boards, when they're seeing behavior that doesn't align to what we need to have happen, they will pick up the phone and call their fellow peer physician and have a candid conversation with them regarding what needs to change. So that's really important. The other thing is at the PHO level, we have what we call field operations, administrative support, that on a primary care basis meets with them on a monthly basis to share their results, talk about things that are going on in the industry, things like that. So really localizing population health, we firmly believe, is a key to success when you're talking change management and behavior that you're looking at. One of the key things we think is really important in population health is the ability to measure. Historically, we have called this advocate care, and so as a result, we had what we refer to as the advocate care index, and it's really an index of metrics that we believe are important to moving the dial on population health. What this slide depicts is that we have evolved continuously all the way back to 2011 when we first became a true accountable care organization, and evolution continues to this day, and we'll talk a little bit about that in future slides. But at the core of all this is the key, our belief is you have to know what populations are you focused on, what are the metrics. There's a gazillion million metrics you could pick. What are the metrics that are actually meaningful, that are going to move the dial on what you're trying to accomplish, because you can't measure everything. And then on the right there, you see two two themes. What's the benchmark? What are you really trying to say makes you best in class? And then obviously using those to set what your goals that you're trying to achieve are. So one way that we think and go about this is this framework. It really comes out of a DuPont analysis, where if you start on the far right where it's labeled true north, you start with what is the outcome you're trying to achieve. And so in our world, we put here the Advocate Care Index total expense per member per month. So total expense PMPM. That's what we're really trying to move the needle on. You may say, well, gee, I don't see quality on here, and that's true. There's a whole different set of quality metrics. This is how do we break that total cost of care down into manageable chunks. So in a DuPont analysis, you start on the right, here's my true north expense, and then you begin breaking it down. So as you go to the left, what are the drivers of the true north metrics? In our focus here, the three big drivers that we want to focus on are emergency room expense, which is ED expense, hospitalizations expense, which is somebody that's admitted or being observed at our hospital, and then SNF, or skilled nursing facility expense. Those are the three key things that really drive the total. And then as you continue going to the left, you want to break those into more manageable, digestible chunks. So if you take the ED expense as an example, how many ED visits do we have per 1,000 members in our population? So that's the ED visits per 1,000. And then if you break that even further down, going to the left, what are those avoidable ED visits, emergency room visits? Meaning, if you look at criteria, we believe about 40% of the visits of people going to the emergency room are unnecessary. So how do we get at changing behaviors of the patients, and what do the physicians need to do to help change that? Or now also the employer. So that's really how we think about measurement. You start at the top and you move to the left. In our world as well, the true north and drivers are medical claim based. So these are very old. It takes 3 to 4 months for the claims to move through the system, so very hard to react to. As you move further to the left and get more action oriented, we begin using local systems, or our systems in our hospitals and medical groups, and Healthy Intent, frankly, to figure out how do we get this more real time. So if somebody wants to measure it on a daily basis, they could do so that they can have some action. With that, I'm going to turn it over to Dr. Nelson, who will go through some more of this information, get into results, and then I'll wrap it up at the end.
Okay, great. So this is the graph of what Don just explained to you in terms of the advocate care, which we're now transitioning the language over to accountable care index. And this is what we saw throughout the year last year. So very nice, steady decline in that total cost of care. This is a blended per member per month rate between our capitated business, our shared savings, and so it would be HMO commercial capitation, as well as Medicare Advantage and shared savings. And so we've seen upwards of a 9% decline over the course of this last year. And much of that is attributable to the structures that we've put in place to be able to drive the improvement at the local level. I'm going to unpack that a little bit further here. This is a much more detailed view of what I just described, and it breaks it out by the individual PHOs. What you see is the blue is they've achieved the maximum target, green is they've achieved target, and then white, they didn't achieve the target. So very significant results. And the far right upper green box that you see at the very top is the system level performance. So we roll it all up together, and then leadership was held accountable for that system level performance in terms of their ability to help support the changes needed. This is a slide that describes for you the structure for driving the utilization improvement throughout the system. And so as Don mentioned, we have we have PHOs at each of our hospitals. Within each of those PHOs, they have
Looks like we've lost our presenters again. We'll give them a couple more minutes to dial back in. Just to remind you guys, while we're waiting for our presenters to rejoin us, if you want to ask any questions, go to slido.com and use the hashtag international learning.
All right, I'm back. Moving to the middle portion of this slide, which is a structure that supports both the local improvement and system level improvement activities. So that's called the Medical Economics Committee. Much of the membership of that committee would be a lot of staff that work for advocate physician partners, but also a lot of analytics folks, and this is where we bring together also the medical group leadership with the aligned physician leadership. And so the key activities of that group are to maintain what we call the utilization improvement portfolio. We know there's a lot of good work that goes on around our system in order to try and improve the utilization, decrease readmissions, work along those lines. And many times those initiatives are well-intentioned but may not have strong measurement associated with them and may not know how to target the patients that might be good candidates for those interventions. One example we use is we have at one of our hospitals a mobile integrated care unit that is staffed by a paramedic, and the paramedic will go to a patient's home after a discharge and make sure that everything is going okay for those that might be particularly high risk of readmissions. When there's not good return on investment measurement, sometimes when budget changes and budget constraints come into play, those initiatives are the exact first ones that are determined to go by the wayside. But we will support some of the work that might be going on around the system to make sure there's strong measurement associated with it. And then when we see something that's going really well, we have strategies that will position it for scaling around our system. So another example I'll give is work that was going on at one of our hospitals to try and increase early ambulation and get better collaboration going between the inpatient physical therapy team and the nursing staff to be able to maximize the functionality of our patients and decrease the need for SNF, for a skilled nursing facility upon discharge. And so what we did was we put together a collaborative to work with our health system across the enterprise to help them adopt the changes that had been implemented at that particular site. And so that's where we recognize that we can contribute to system level improvement by identifying those things that are going really well. We also might find opportunities that nobody's doing within our system, but we need a solution for, and we will identify those and put pilots in place and then position them for scaling. That committee also looks at the PHO level performance, so the individual PHO, how are they doing with the Advocate Care Index, with their financial performance in general, but also stays in touch with individual contract level performance. So you'll see nuances of differences between what we might see in our commercial capitation contracts versus our Medicare Shared Savings Program. And I talked about the scaling. What the right-hand side represents is our Safety, Health Outcomes, and Experience Council, affectionately known as SHEC. And that is a body that has a lot of different medical leadership from around the system that comes together on a monthly basis. So we have well over 100 members of that. We will have chief nurses. We have our vice presidents of medical management. We have medical group leadership. We have quality leadership. We have analytics folks, a whole range of people there that are keeping an eye on the full system performance on health outcomes and patient experience and safety. And so that group, when we identify something in particular that we think is worthy of scaling, that group contains the local the local leadership that can help to maintain the accountability for site participation in those scaled initiatives. And so that's a really important way to make sure that we get the endorsement at a very high level to implement changes that we think are necessary throughout the system. The next thing I'll turn to in terms of a way that we have bridged the continuum. So that structure I just described, I think, is very essential to making sure that we're bridging that continuum, which is really where we started with this conversation in terms of bringing hospitals together with the ambulatory sites of care to drive the improvement. So care management innovation is really sort of a nervous system of the health system that is very much focused on making sure that they're optimizing next site of care, that patients have, they're a safety net for patients. And so when people go to their homes, did all the, the DME, get delivered, did home health come to the house, or if they're needing to go to a post-acute, a SNF, for example, when they go home from that SNF, are we making sure that's a smooth transition? So there's a lot of collaboration that we've put in place now to bridge the continuum with care management. Previously, we had been functioning in silos where we had an inpatient care management and an outpatient care management structure that had different reporting structures. And sometimes what we found there were the priorities were different. And so on the inpatient side, you would see that length of stay was a major focus. And yet on the outpatient side, sometimes we would realize that if we just kept a patient in the hospital for an extra day or so, they could go to a lower cost of care setting on discharge. So instead of having go to a long-term acute care facility, they could go home to they could go to a SNF, or instead of a SNF, they could go home with home care. And so what we've done now is to bring that all up under one single reporting structure. And so I have a vice president of care management on the Illinois side, integrated care management, and one on the Wisconsin side that report up to me. And that has been a real game changer. And we've put a number of solutions in place that are part of that program. So in the emergency department at our largest tertiary quaternary health center, we have admission avoidance support. So that would be care management. We've amped up care management in the emergency department. So sometimes physicians, when they have a person that is, on the bubble, we say, so they could certainly meet criteria for being admitted, but if they had the right sort of support to transition them and keep them safe in the outpatient environments and get the same level of care, that would be a better alternative for us from a total cost of care perspective. But what they need is support. They need a group of personnel that are able to help them support getting the pieces in place so that if they need to go home, do they have an appointment set up for their primary care physician the next day? If they need to go home with home health, how do we make arrangements for that? Same with if they can go right to a SNF. So that those ED care management staff in that emergency room are really helping to support admission avoidance. We need tools for managing complexity. So it's a very complex patient population and lots of different aspects of that complexity that we're asking our staff to manage. So there's certainly disease-specific complexity, there's social determinants of health, and then there's the payer that they are associated with. And so from a clinical standpoint, we manage patients all the same. We want to make sure everybody's getting the same excellent clinical care. But we need to make sure that we know when they need extra resources outside the health system, where we get those resources. And so much of that is dependent upon their payer source and in the states anyway. And so if they're in full capitated plan within our health system, we've built a lot of those resources. If they're more of a straight fee-for-service type of patient, then our health system has built those resources, or that their payer source has built the resources. We have a care transitions team that manages patients for 30 to 90 days post-discharge and has been able to see a decrease in readmission rate by about 30%. And then we have at each of the PHOs now an interdisciplinary care team that comes together. It will be composed of pharmacists, care management staff, physician leadership, social workers, and the like, both care management on the inpatient and outpatient side, that talk about the folks that need to be discussed any given week that are part of that PHO's patient population. They might be people that are in the hospital. They might be people that are very complex that our care management teams are working to manage and need some extra brain power to help identify solutions for them. And then finally, we have post-acute solutions that we've really built out extensively over recent years. And so that, I'll move to the next slide. So our post-acute, what you see here are the various post-acute solutions that we have in place. And the light green circles represent the things that were in place probably prior to 2008 or so when we first got into shared savings agreements. And since then, we've built out quite a bit of extra capacity. I'll just hit on a couple of these things. Palliative care at home is a real value for our patients. We know that we need to pay attention to the goals of care, and we need to have resources available to our patients that help them achieve those goals of care. So palliative care at home is an important resource. Our SNF program, we don't own any post-acute facilities. We do own our own home health, but in terms of the skilled nursing facilities, what we do is we partner with facilities that where we've identified a lot of our patients are already going, and we look at their quality performance, and then we put a physician partnered with some advanced care planning or advanced care clinicians, I should say, like nurse practitioners in those sites, and they work with making sure they're rounding on patients on a much more regular basis, idealizing the length of stay so that they get home at an efficient interval, and that they're decreasing their risk of readmissions. We also have a physician at home program for people that are homebound, and then a transition program for people that may not be eligible for home health but can benefit from having someone look in on them at home to decrease their readmission risk. And that's, I think, where we're going to pause for questions before we get into results.
So just bring the questions up on screen now.
They have like a
Okay, great.
Okay, well, let's bundle the questions, I think. So we've got, in terms of the measurement issues, how did you decide the population health element in the advocate care index, and how have you actually worked pop health outcomes into those? And then I think if we take the third question, how did you decide which metrics to focus on, and do you measure against the quad aim?
Yeah, so I'll start, and Carrie can certainly jump in. So as I'd mentioned, the Advocate Care Index, the ACI, you'll notice is very financially driven. We have a whole separate set of metrics on the quality side in what we call CI. There's up to 150 different measures that not one physician has that many. I think the primary cares have in the high 30s, low 40 number of metrics. So the quality is somewhat on the side, but if you look at some of the things that are in the Advocate Care Index from a financial perspective, they are absolutely linked to quality. So for instance, before we got involved in managing the skilled nursing facility patients directly with our own APNs and physicians, excuse me, the length of stay was 25 days. Since we've measured it, the length of stay has dropped down to 14. And clearly, a patient being at home is more important than a patient, is better than a patient being in a skilled nursing facility. And readmission rates went the same way. And same on the hospital front is a patient that's in the hospital is more expensive, but it's also not the best place for a patient if there's a lower acuity side of care. So there is a linkage, and I'll let Carrie talk about that in a moment. Lastly, the reason we picked the financial metrics that we have in the Advocate Care Index is, frankly, we looked at what were the biggest sources of spend or cost to us from a total cost of care perspective. And really facility costs, SNFs, hospitals and emergency rooms all kind of show up. There's additional work done at the PHO level on the professional fee side of things. So we're not ignoring the non-facility costs, but they're done via a different mechanism. The Advocate Care Index really just represents the biggest cost. And I'll let Carrie add.
Yeah, and the Advocate Care Index, it's a little over 50% of the cost. And so it is important for our PHOs to look at the other 50%, and much of that is clinical variation. And it's pharmacy costs, too. We're seeing very significant increases in pharmacy costs. So there's a lot of work that's done there as well at those Advocate Care Index committees. In terms of measuring the quadruple aim, this is a very, what I have insisted upon for our initiatives. Any of the work we do has to have a metric, at least in each of those domains. And so when we put a solution in place, so for example, we have pharmacists that are working on medication dose titration for people with diabetes to be able to get them to goal more efficiently, kind of getting away from the clinical inertia that we know is a common issue with physician practice. We need to make sure that aside from change management concerns that people might have, we have to move through the change management. But when, in the end of the day, how are the physicians feeling about the support that those initiatives are providing to them and getting to quality results? And so, yes, we do measure against the quadruple aim. And as Don said, days at home is a metric in particular we're very focused on, and we've seen some nice improvements in days at home. We think that's one of the patient-centered metrics we could think of.
And I just add on the quadruple aim piece. So we do physician engagement surveys, which are not a perfect measure of physician engagement in health, but that's at least a quantitative way to do it. The other thing we know is the administrative burden of the entire clinical integration program is pretty real to a physician in their office.
Looks like we've lost our presenters again, so we'll give them a minute or two to get back to answering questions. Hi guys, are you back on the line? Give it another minute or so.
Looks like it's connected.
Okay, now we're good. All right.
Go. Thanks,
All right, can you hear? All right, so we'll continue. I'm not sure where it left off, but bottom line, we know our clinical integration pop health programs have a certain administrative burden to the physician, to the clinician. So we've been working hard on automating all that to the extent that the physician can just do their job, be a clinical physician like they would enjoy being, and make it more measurement on the back end. We have a ways to go still, but that's kind of the focus point that we have.
So I see a question highlighted. STP, I'm not sure what STP stands for. I imagine it's something similar to what we do.
Yeah.
Well, I think if you assume an STP is the local healthcare system, so I think the gist of the question is that a number of the systems in the NHS struggle to encourage, get GPs particularly to actually act collaboratively and also with their secondary care clinicians, in the interest of the overall system and getting the best outcome. So it was really, have you got any lessons around actually how do you persuade clinicians to act for the common good?
Yeah, so I'd go back to the governance slides that we shared. That circle that I talked about that started with culture and include shared governance. At the end of the day, what we would say is the success is physicians have to be engaged in the governance process. It can't be a top-down thing where administrators somewhere push stuff upon them. They need to have a seat at the table. And second, there needs to be a reward, an incentive for them to participate. And certainly within our model, there's significant financial rewards, but it doesn't always have to be financial. How do you make their work better? How do you make them feel this is going to benefit their patients? So somehow there has to be an incentive and there has to be shared governance. Nobody in a change model wants to be told what to do. They want to be part of the solution, making the solution.
The other things I would add are, we have a couple different ways we interface with our docs in their practices. So we have field operations staff that are out there visiting primary care physicians on a monthly basis and helping them understand where their care gaps are and providing them with resources to help close those gaps. And we also have a performance improvement team that will work with them to help improve workflow. And we've had, for example, training that we've done for their staff on blood pressure measurement to make sure that they're measuring it properly and then achieving blood pressure control.
And I would say it doesn't come without angst along the way.
Yep.
We've had physicians leave the organization. Often they come back a few years later because they thought the grass was greener somewhere else and it wasn't. We get pushback because we at the board level with support from my management team, we're looking ahead. We're looking at all the disruption occurring. We're trying to, our motto is, because we have so many independent aligned doctors, if you want to be independent aligned, we're happy to help you do that. If you want to be employed, we'd like you to join our employed group. But at the end of the day, we want to make you successful as a physician so you can be a physician. That means in our industry in the United States, there's a whole lot of disruption, but there's also a whole lot of regulation changes and things like that. So helping them navigate that's part of the value equation. But then again, the incentives. But I really, if I had to boil it down, is if they did not have a seat at the governance table, I think we'd have a whole lot harder time.
Yeah, and there's lots of levels we include them. So they're sitting on the PHO boards, and they're also involved in those Advocate Care Index committees. The last question I'll just address as well. We do have one system. We do recognize the need to use AI and machine learning. I will say that we have a natural language processing program that we're now scaling for congestive heart failure. One of the things we recognized is we have these heart failure clinics at our hospitals that have tremendous results in terms of decreasing readmissions when they actually can see the patients. And so they can get close to a readmission of 0 for some of the patients that they're caring for. However, we found that our nurse practitioners that staff those are oftentimes spending a lot of time in the chart looking for the patients that they should be seeing. And they were seeing only probably 8 patients a day in the clinic. We needed to create efficiencies there. So now we do have the natural language processing system in place that's helping to identify patients more readily, more consistently, and without the staff burden that had been there before, so that they're able to be more productive. We also recognize just the tremendous potential of being able to manage by exception and providing more of the AI machine learning capabilities to help our care managers make sure they're reaching out to the patients who really need to be reached out to on any given day.
Okay. Can we just build on that then? So machine learning and AI, yes, it's enabling you to actually target at-risk patients more easily. One of the big challenges we face, which you must as well, is actually the workforce one. So the extent to which we can actually use particularly our expensive clinical staff more effectively and either actually automate some of the interactions or actually being able to then actually empower staff who haven't got a clinical background but have actually got good customer service skills and so on. So I'm interested in the extent to which you see using AI and machine learning approaches as being a way to help you with your workforce challenges.
Yes.
It's absolutely true. I mean, these are expensive staff, and care management can be very, very time consuming, and we want to make sure that they're reaching out to the right people. We are working with Cerner to
You're going to get into it in just a second.
Develop the episodic care management. Yes, we do have an example here in a moment that we'll share with you that has been of tremendous value to making sure we're reaching out to the right patients using those kinds of technologies.
And I think from that perspective, if I understood the question, it's like, hey, we have these really expensive people resources that we want to use their empathy, their clinical skill, et cetera, things that machines don't do well.
Right.
But we'd like to make sure they're focused on the right people. I think that is really where Carrie was going, is a couple things. When we talk about our care management program, we several years ago had realized that, once a person entered care management, they stayed for a long time. And a lot of it was, elderly, loneliness people, things like that. And so the care managers felt good because they were working with them. But how do you make sure the right patients are getting the right level of resources? So we do some things that are non-AI related to make sure that we're closing out cases and moving on to the people that are best use of that resources. But at the same time, the AI stuff, the machine learning stuff, and Carrie talked about natural language processing, and what you'll see in a second is how do we identify the right people, so the signal from the noise. And that's really where this heart failure project that Carrie was referring to really comes in, because just identifying that patient and then getting them to the right resources. So I think it's both what I'd call old school management of making sure that you have a finite resource, you're really applying it to the right people, that once people have hit a certain graduation or threshold, you move them on and take the next people available. But then complementing that with AI or machine learning. And even frankly, the next step I think a lot about is, that those virtual call outs where it's a machine calling somebody to check on them versus a person, and then doing a warm handoff to a person. So I think that's what we need to do.
Yep.
That sounds like a good point then, I think, to go back to the presentation. You were talking about a case study that might be of interest.
All right. Do we do that?
They'll change it over to you.
Okay. Oops. Did I mess up? Oh my God.
Oh, boy.
Okay, what did I do?
Fall out again?
I think my understanding is your
Resume.
okay, there we go. Resume slideshow.
Did
You're
we
definitely
drop?
still on. No, you're still on. I still see you.
Okay.
I don't see your slides. Let me see if you're.
Does he have to change it off Slido?
Yeah, do we need to take it off Slido to be able to get back to the slides?
Yeah, you should be able to, if you click on share at the top of WebEx.
Oh, okay. We found the way.
Perfect.
Okay.
There we go.
All right. Excellent. Okay.
I think if you tick the box that says use presenter view in the right-hand corner, then it should work.
There we go.
Okay. Got it. Okay. Got it. Okay. Here we are. All right. So the first slide up here is exactly what you were all just asking about. We've been calling it episodic care management. And what we found was that we developed a tool that would identify patients. It's the AUP,
Yeah, it's a predictive model.
a predictive model that identifies patients that have heart failure that are at great risk of utilization within the very near future. And what we then do is we're able to tee that information up for our care managers to do the reach out. So much of care management, they might be reaching out to patients with chronic conditions, with end organ damage. They're reaching out to them on a monthly basis to try and help them better self-manage their care. But in this scenario, able to identify people that are very near the risk of acute utilization. And so they reach out to them much more frequently, sometimes several times in a week, to be able to help make sure that, for example, if they've had a weight gain and their heart failure, then they're really doing their best with their diuretics and in touch with their healthcare team. And so we had 4 care managers that were very involved and some 200 patients that were enrolled. And they achieved very nice benefits. So 2 analyses showed that this resulted in a 23% reduction in the acute encounters. And so we found there was about 7 days, average number of days between patient contacts. So much more frequently, as I mentioned, and then about the 90% of the patients were actually meeting the goal based on that intervention. So this is an example of using machine learning to be able to identify those folks much more readily.
I think it's also an example of, we have a lot of innovative products like this that we're working on, and you may say, well, gee, this was only 76 patients. And what we've come to conclude is we have to be willing to move faster, which means even if it's not statistically relevant, but it seems logical, and the early data shows promise to actually deploy it faster, and just be willing from time to time. We'll make the wrong decision. We'll just have to be willing to undo it. So this is an example, small sample size, but logically made sense. We like the results we're seeing, so we're actually scaling it across the enterprise, recognizing there's some risk involved.
And then we're also using the same methodology for PD in the near future. This speaks to some of our quality performance. We feel very excited. We've been doing the quality improvement work really for the last probably 15 years with our clinical integration program, working across that platform of physicians to drive results. It's more recent that we've had more of a focus on the total cost of care. And so asthma outcomes, you can see nice control rates, very significant increase above the national average. And then we like to make the translation in terms of what that means to direct and indirect medical costs and worker productivity. Same for diabetes outcomes. You can see the results there. This is a nice example of how things can come together across the continuum to be able to drive an improvement that's important for the hospital side and engage the physicians in that work. So we found that many of our physicians weren't practicing with the current state of knowledge on how to use blood products. And so we put an education program in place and an incentive for engaging with this initiative. And we were able to see some very nice improvements in blood utilization. And this is a precious resource that we can't afford to overuse. The other aspect of this is that we know that overuse of blood products, it can be a very dangerous thing, and that it actually can create harm. And it also creates a lot of staff, it creates a lot of staff work. And so this is an example of the sweet spot where efficiency and quality come together very nicely. And then post-acute care, as we mentioned, very nice improvements in readmission rates, a 34% decrease in total cost of care for Medicare Advantage that's attributable to our home-based palliative care patients that have received that initiative. And then, as we mentioned, the partnered skilled nursing facilities with a nice decrease in the length of stay and readmissions. This is something that we looked back after doing this work for a number of years. We serve a very diverse patient population in the Chicago area. We have, very impoverished communities that our hospitals are located in, that our physicians are practicing in, and then we have
Looks like we've lost our presenters for another time. I think, again, just a quick reminder, if you want to ask any questions, we'll have a couple of minutes of questions at the end as well. So if you go to slido.com and use the hashtag international learning, you can vote up and down existing questions that are there as well, so that we can pick them up at the end.
There you are. All right, there we are. We're back. So these are cost savings. In Illinois, we've had a large Medicare Shared Savings Program. That's MSSP. We have saved about $165 million, and we've had some very good quality scores in component of that. So the way that program works is that based on our savings, we will share in half of the savings, roughly, with the government, and the portion that we take home, that we get to put into our incentive program and that we get to reinvest in the solutions we have, that's the quality score is a multiplier. So if you do poorly in quality, you take home less of the savings and vice versa. And then with our own employee patient population, about a 10% reduction in medical costs. And then other impacts to the continuum. So hospital supply chain, a lot of expensive equipment at the hospital. We're able to, engage our physicians through the incentive program and through all the different structures we have in place to get the system working together. Some nice improvements in supply chain costs. We have a behavioral health program, and we're building out a full behavioral health integration solution. But suffice it to say that the first steps of that was a telemedicine behavioral health program that is supporting patients in the hospital, patients in the emergency department that are they have a significant behavioral health comorbid, and we've seen a significant drop in their lengths of stay, their readmission rates, and things along those lines. We have a Medicaid value-based contract. That's the safety net. Medicaid is for patients that don't have insurance and have live at some portion or some percentage of the poverty level, and we have achieved about $800,000 in shared savings through success with that contract. And then again, just evolving to integrating the care to deliver value. So traditionally, the American healthcare system has been focused on rewarding volume instead of value, and all of this work has really helped to evolve the culture further towards delivering on value.
So we'll summarize this as to the top lessons learned, and some of this is very directly related to how your health system is structured. Some of it you may have to say, okay, what does that mean in our world? These are in no particular order. We just listed them out. But number one is accountability. And what we see when we talk to others across the country is you really need to integrate and hold accountable all aspects of the continuum. So in our world, it's hospitals and clinicians, but it would also include the SNFs, et cetera. So everybody's got to be accountable, which means number two is everybody has to understand what the defined goal and measure success is. So if you all are working at different purposes, it's going to be hard to hold each other accountable. We've mentioned this several times. We believe shared governance is really, really critical. Clinicians and administrators have different skill sets, and they need to be working side by side. Number four is, again, this comes from more a board level, but there has to be a fiduciary responsibility, meaning people in the CIN are working on behalf of the CIN, not for their own individual gain. Number five, we do believe you have to reward people for their work, be it clinicians, hospitals, or SNFs. It's just human nature. If there's no reward, folks are going to do what's in their best self-interest versus being enlightened. Number six, again, more pertinent to us, but managed care contracts must align and reinforce the desired behavior. And what we mean by that is the benefit design, as an example, is as you have employer-sponsored insurance, and I'm not sure at the government level how this would work for you guys, but it's more expensive. The cost share, the part that the individual consumer bears, is more expensive for them to go to the hospital or the ED, so that hospital's the most expensive, and then the individual primary care office is the least expensive, and there's a graduated fee schedule along the way to incent their behavior. Number seven, all this stuff requires significant infrastructure, and as we mentioned with the evolving CHF care management program, you have to be willing to put some bets down. So try some infrastructure and continuously evaluate the return on investment of that infrastructure, and not being afraid to say, you know what, it was a great idea on paper, it didn't work, and walk away. Or if early on it's showing promise, scale as soon as you can. This goes hand in hand is the sheer number of vendors and peddlers calling us to try to sell us something is immense, and trying to be strict around how do you evaluate if any of that makes sense. In our world, data and risk coding are the new currency. Data because it tells us where to go and tells us if we're being successful. Risk coding because many of our contracts with the government and with individual and payers are based on the acuity of the patient drives our reimbursement. So making sure we're coding accurately so we understand that. And because we bear financial risk, number 9, actuarial support is really complicated math, and we need to make sure we're looking at it the right way so we're not taking on a disproportionate share of financial risk without the associated reward. 10 goes back to the accountability. You need to be really explicitly clear on what's your common purpose and objectives, and then hold everybody accountable. We find that sometimes it's not clear, then you have people thinking they're acting in the best interest, but at the end of the day, you're going nowhere together. And then lastly, be transparent on everything. Over our history, we've had a lot of really rough patches where we had hard choices and decisions that not everybody agreed with. but working with our board, we thought was the right direction for the organization, and we stuck to our guns, and we were transparent about what we were doing and why we were doing it. It didn't mean all 5,000 physicians and all 11 hospitals thought it was the best thing to do, but we stuck to our guns and did it because we believed it was the right thing. So at any rate, we're very humble about this work. We're excited about where we've been and where we're going, but we realize there's a whole lot more work, a lot more experiences we will have, both positive and negative, but it's where we have to go to transform. We know our healthcare system's much, much too expensive and not producing at the level we'd like to on the quality front. So in our view, the work continues, and this is a good foundation from which we start. So I think that's our last slide.
We're at 10 o'clock.
That was great. Well, I think we probably are okay for a couple of questions, if that's okay with you. One is, I know you've got field improvement teams. Have we lost it? You've got field improvement teams, but when you start picking up that something's going seriously wrong, what's your approach? How do you intervene?
Yeah, no, so we have very direct conversations. What Carrie, I don't think we really talked a lot about is each of our PHOs has a medical director, a physician who reports directly to Carrie. And if it's something on an individual behavior, Carrie and her medical director team will get involved. If it's more systematic, that's where we spend a lot of time. Heart failure is a great example. We know when the patients go to a heart failure clinic, their readmission rates are in the single digits. Yet not all our patients go to the heart failure clinic. So that's where we look systematically to say, what's our analysis, what's the conclusion, and what do we do about it?
Yeah, the other thing I would add is, in a scenario where we don't have, the financial performance is not happening at one of the PHOs, we have a corrective action plan that we put in place, and that is overseen by the Contract and Financing Committee. And so they come to the Contract and Financing Committee, talk about their corrective action plan, and they're on a schedule then to be able to get it on a better footing.
And the last thing we'd say, the clinical integration, the CI score we referenced, every individual physician has a CI score. It's on a percent, 0 to 100. And every year we review and we put a floor in, and it more recently is at 60%. And if an individual physician falls below that score for the year, they're put on probation. They do not get an incentive check for the 2 years that they're on probation. And if they fail to correct, they will be out of the system. So, make no mistake about it. We've talked about a lot of the good things, but that's where shared governance is so important, is a lot of those hard conversations.
That was great. That's probably a good point to actually finish on. Can I take this opportunity to thank you? That was a fascinating presentation, and you were very honest in your responses. So thank you very much indeed, and have a good day.
It's been a pleasure.
You
Thank
too.
you.
Take care.
Have a great day.
Thank you.